Hello, I'm Dr. Jonathan Silverberg. I'm a professor of dermatology and director of clinical research and patch testing at the George Washington University School of Medicine and Health Sciences in Washington, D.C. Standardizing shared decision-making conversations is not always easy to do. I think the first thing is to be comfortable with the data, at least the top-line results, understanding for any new drug or any drug that we have approved now, what are the kinetics of response, just how robust of a response one gets. Are there advantages? Does it work well as a monotherapy versus combination therapy with topicals? How long will they have to be on therapy in order to first see a response, and what timing towards peak response? You may not have to memorize those numbers, but you should have at least in your mind that comparative effectiveness between the different therapies. So that's one issue. Two is you definitely want to keep up with the safety profile. And that's where, at that point, it's not standardized anymore, in a sense, because your spiel, your discussion around the adverse events can be very standardized because you know what the most common adverse events are, what to expect, or what are the rare serious adverse events for different therapies. But it's important, from my perspective, if I think there's an absolute contraindication or a relative contraindication to a therapy, I won't mention it as one of those options. So I will tailor that treatment's shared decision-making conversation based on the patient's underlying comorbidities, risk factors, etc. And I will even mention in passing to them, there is another therapeutic option which for other patients would have mentioned, but I don't think it's the right option for you for reasons X, Y, and Z. And I think it's important just to let them know that you're not just giving them the one-size-fits-all, that you really are tailoring it to their specific needs. But of course, then every patient is different in terms of what their level of risk is.